day and welcome to the Association of State and Territorial Health Officials deck-side briefing on COVID-19 vaccination plans and funding. Today's conference is being recorded and is on the record. At this time, I would like to turn the conference over to Mr. James Blumenstock. Please go ahead, sir.
Katrina, thank you so very much. Good afternoon and welcome to today's media call with the Association of State and Territorial Health Officials. Thank you so much for joining us as we will be discussing this very important topic of preparing for the COVID-19 National Vaccination Campaign. My name is Jim Blumenstock, and I am certainly privileged to serve as the Senior Vice President for Pandemic Response and Recovery at ASTHO, and I will be serving as the moderator for today's briefing. As many of you know, when CDC released its COVID-19 interim playbook for jurisdictional operations on September 16, states, the territories, and the directly funded cities were given 30 days to prepare and submit their vaccination plans to CDC that would then be subjected to technical review and comment. Since there was considerable media interest in this, we thought it would be very helpful to all to host this call to really give you an opportunity to hear more from our folks in the field and have a discussion around the planning efforts in a little more detail. We'd also like to cover a little bit of the resource needs for successful campaign implementation and also the critical importance of building vaccine confidence in the eyes of the public to really increase vaccine uptake during the course of this campaign. It's really important to stress that planning did not start on September 16th. State and territorial health departments have been in the planning phase for months. They've been updating and refreshing their existing pandemic plans based on real-time and real-world experiences associated with the emergence of COVID-19, while also drawing upon the lessons they learned during the H1N1 influenza pandemic some 10 or 11 years ago. Also in August, CDC provided the states and territories with initial detailed COVID-19 vaccination planning guidance. This was in the form of key planning assumptions, providing a set of planning scenarios, and also a checklist for the states and territories to follow. Another point worth stressing before we turn to our experts is that planning for this historic public health undertaking is truly a work in progress. What was submitted on Friday are not final plans. Far from it. This is an iterative process. The jurisdictions will continue to expand and refine their plans as time goes on, and as more is known, and as states and territories continue to examine and determine what are the best strategic approaches and tactical actions necessary for the safe, efficient, and equitable administration of COVID-19 vaccine. Now, it is truly my pleasure to introduce to you our expert panel. First, we have Dr. Nirav Shah. Dr. Shah is the director of the Maine Center for Disease Control and Prevention and also chairs ASTHO's Infectious Disease Policy Committee. Dr. Shah will be followed by Dr. Thomas Dobbs, who is the State Health Officer for the Mississippi State Department of Health and is the co-chair of the Infectious Disease Policy Committee at ASTHO. And then we'll hear from Ms. Claire Hannan. Claire is the Executive Director of the Association of Immunization Managers. Each of our three panelists will provide brief prepared remarks in sequence, and then we will entertain all of your questions and have a conversation at the end. So with that, Dr. Shah, let me turn the program over to you, sir.
Great. Thank you, Jim, and good afternoon to all of our colleagues in the media. Thank you so much for joining us for this briefing. Again, my name is Dr. Nirav Shah. I'm the director of the State of Maine's Center for Disease Control and Prevention, which is the public health department here in Maine. And I will go ahead and just share a couple of things that are relevant to our state as we have been engaged in the planning process. I'd like to underscore what Jim just noted, which is that for us, our planning in earnest for a potential COVID vaccine started just shortly after our mitigation response did in the beginning of this year. So we've been planning this for several months now. And planning for a vaccine that has not arrived, for which clinical data in different groups are unknown, for which the handling of the vaccines has not been well characterized, all of those factors make planning for the eventual possibility of COVID-19 vaccines a significant challenge. But I think it's important to note that this is what state health departments do, and this is what we have done throughout the entire COVID-19 pandemic. We plan and respond in situations where data are insufficient and where there are more unknowns than knowns. But this is just the nature of modern public health, particularly in times like this. Part of our planning process, thus, necessarily involves recognizing that things will change as we learn more scientific data as well as operational data. And thus, within our plans are specifications around where and when we will be flexible. For me, it's a little bit in our state like planning an outdoor picnic for 1.3 million of my closest friends, but not knowing what kind of food I've got in the pantry, when that food will show up, how long the food will be good for, who's going to be coming, how I'm going to invite them, and what they can and can't eat. There are more unknowns than knowns, but this is just what we do. We plan for the things for which we have knowledge around, and then we move forward from there. In our state, one of our key areas of focus is identifying vulnerable populations. For us, that means several key groups. The first are those who are racial and ethnic minorities, and ensuring that we have a mechanism to reach out to them and provide vaccine. In addition, we're especially concerned with and working with tribal communities as well. Second, given the older than average population in Maine, we are particularly solicitous for the concerns of elderly populations, both those who happen to live in long-term care facilities as well as those outside of those facilities. And then third, given the rural character of Maine, we've got to make sure that any vaccine we have can get to that last mile issue so that we fully have a plan that gets the vaccine from our warehouse literally to every single person. In order to do all of those things, what we need in Maine is funding. ASTHO has recommended approximately $8.4 billion plus an additional $500 million to be distributed to states to assist with this funding. Without more federal funding, this is kind of like setting up tent poles without having the tent. In Maine, at least, we would use the funding for at least four key things. The first is having the human resources to actually serve as vaccinators. The second is the IT and data systems to track who's been vaccinated and when they need to come back for their second dose, as well as to follow up with them. The third is to support logistics around delivery, transportation, and operations. Minus 80 freezers are pricey. And then the fourth is, of course, around communications. We're going to need a concerted, focused campaign in order to generate confidence around a vaccine, as well as to ease any anxiety, something that we know from data, something that's on the increase. So with that, I'll conclude my remarks and turn things over to Dr. Dobbs.
Hey, good morning. This is Dr. Thomas Dobbs from Mississippi. Thank you, Dr. Shah, and appreciate everybody being here, and especially appreciate the great work of ASTHO as real public health leaders during this pandemic response. Talking a little bit about our perspective of getting ready, you know, all public health departments have the benefit of ongoing planning. This is something we do year after year as we look toward an immunization release for a global pandemic. We also have the experience of H1N1, and we'll be able to learn from that to make sure what we do in the future is going to be far more effective. If we think about the different phases of potential vaccine availability, we know on the phase one, it'll be, not that it's going to be easy, but it's going to be easier. We already have recruited partners. We have plans for closed points of distribution. We have mechanisms of distribution that are already sort of pre-established. And that's going to be for folks who are going to be higher risk, not only for getting it, but also higher risk from adverse events if they do get it. But if we think about moving on to the phase two or even phase three as far as like trying to reach all populations with an effective vaccine, that's going to be a real challenge, and there's several different barriers that we face going into that are relatively unique. One of them is going to be trust. It's so important that general population trust the science, trusts the government, trusts the public health leaders to understand what the real benefit is. If we have a great vaccine and people don't get it, it doesn't do us any good. And so we have multiple needs around that, but one of the things that we desperately need is going to be a unified, science-based communications effort from all levels, from the federal, state, local, making sure that we all are speaking with a similar voice. Now, part of that is making sure the science is right, and I have no doubt that the public health leaders are going to make sure that the safety and efficacy is going to be held to task because we're all watching it extremely closely. Reaching high-risk populations is going to be extremely important, especially those that maybe don't have best accessibility to health care resources anyway, especially in a rural state like Mississippi with a high percentage of uninsured folks. That's going to be a huge challenge. And then recruiting partners is going to be very important. But when we talk about partners, we know we want to work with pharmacies, we want to work with community health centers, we want to work with private clinics. But thinking back to our experience with H1N1, it's so important to remember the valuable role that public health can play in this sort of endeavor. And as a quick sort of story about how important it is, when we went through H1N1, we recruited private physicians to recruit schools to do testing, to do H1N1 vaccination. And because the nature of their work is very different, it's unit-based, it's based on individual patients, their throughput was painfully slow. The effort was great, but their training, their familiarity was not really able to meet the need as far as rapid throughput. Whereas the public health team, with a handful of nurses and some support staff, could do 1,000 kids in a morning and then go do another 1,000 in the afternoon. Sounds preposterous, I know, but that's what public health is. It is that gap filler. It is that resource that we can turn to when we need to do something extraordinary in a crisis like this. And so part of it is we need to support public health right now, of course. We need funding to be able to do that sort of remarkable work that we know we can do, but we also need sustained funding going into the future because as bad as the coronavirus pandemic is, and it's obviously it's horrendous, this is not going to be our last challenge. It's not going to be our last pandemic. This is something that we should fund stably into the future so that we can be not only as able but even more able when the next thing comes. And that's all I have. And just, again, thank you so much for having me on this panel.
And Claire, we'll turn to you.
Thanks, Jim. Good afternoon. I'm Claire Hannan, Executive Director of the Association of Immunization Managers. Our nonprofit represents the immunization program directors in the 64 jurisdictions funded by CDC for immunization. We're happy to be invited today as an ASTHO affiliate organization. And this is a great check-in point as we prepare for potential COVID vaccine campaign. As Dr. Shah and Dr. Dobbs mentioned, planning has been ongoing. It is still quite an achievement for states to develop this comprehensive planning in 30 days, as Dr. Shah said, without knowing exactly what's in the pantry. But these plans provide a framework for enrolling tens of thousands of providers, for identifying the critical and essential populations, for allocating and distributed vaccine equitably. And the planning process has brought agency-wide leaders together and stakeholders to the table. And this is really a great start. It is just the beginning. These are living documents and will be updated as we learn more about the vaccine candidates, their storage and handling requirements. Dr. Shah mentioned the -80, -70 degrees Celsius, the recommended populations, and more about supply, how many doses will be available and when. I wanted to stress a couple of things as we move forward. First, the communication is critical with providers, with healthcare workers, with the public. Communication about the vaccine, about its value, about the process for its approval, and also about the plans, about how vaccination is going to work, who should get it, and where they can find it. There's an urgent need for engagement and communication with specific communities, such as the tribal and minority populations. And second, again, I want to reemphasize what has already been pointed out, the need for resources. It's one thing to write a strong plan. It's quite another to implement the plan. And right now, these plans, especially on the communication side, are just wish lists. Without additional resources and funding, we won't be able to successfully implement them. It's going to take all of us, federal, state, local governments, communities, the private sector, the public sector, all of us working together in order to fully execute these plans and successfully vaccinate millions of Americans. So I'm happy to be celebrating this milestone, but also very cognizant of the challenges moving forward. Thank you. And I'll turn it back over to you, Jim.
Great, thank you. So we've all been treated to three excellent summary set of comments that really paints, I think, a very vivid picture of the milestone accomplishments to date, but also the road ahead to be fully ready for this historic public health initiative. So with that, Katrina, let me turn back to you, and you could tee up our audience for questions of the panel.
Thank you. If you would like to ask a question, please signal by pressing star 1 on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open. Please state your name and media outlet before posing your question. Again, press star 1 to ask a question, and we'll pause for just a moment to allow everyone the opportunity to signal for questions. And our first question, please go ahead.
Hi, this is Candace Choi calling from the AP. Do you have any guidance yet, either from the CDC, or is there any consensus on whether people will have to go back to the same place for the second dose? And also, I guess the other part of that question is whether or not the providers providing vaccines would have to reserve the second dose.
Great, thank you. Excellent question. Claire, maybe if I could turn to you for a quick answer, and then maybe you augmented by Dr. Shah or Dobbs.
Sure. This is Claire, and I would say that ideally it would be good for people to go to the same place for the second dose, but I think that we will have the data systems in place, and also as a backup, the CDC is also providing cards to folks so that they know which brand of vaccine they got. We do have experience with this immunization information system to do reminder recall and to keep track of doses according to brands. We have some experience with that with meningococcal B, so we are prepared for that. But yeah, ideally get the vaccine in the same place, and then it's just easier all the way around. CDC is not recommending, that providers hold on to doses. I think CDC will be coordinating the allocation strategy centrally, as will the states. It's probably not a good idea to have providers holding on to doses. We want to make sure that we're using the doses the best way we can and spreading them out and keeping track of them centrally and at the state level.
Great. Thank you, Claire. So, Dr. Shah, Dr. Dobbs, anything more to add specific to your state's planning to date on that?
This is Dr. Shah. I'll just say I concur with everything that Claire noted, and for us, or for me, it underscores the importance of having a very robust IT and data substructure infrastructure in place before the first dose is even arrived or administered. Having the vaccines is but one piece of the puzzle. It's all of these somewhat hidden things, like having the IT system that can let us know when someone needs to go back to the same site, or having us have insight into the supply chain so we know how that second dose can be planned for. Those are just as critical as the vaccines themselves.
Excellent points. Thank you.
And this is Thomas. I was going to say that as far as like location of providers, we should have a centralized registry where all registered providers can see what the initial dose was and when it was, such that we could have some variability in where a patient goes to receive that vaccine.
Thank you. Thank you. Katrina, let's go to the next question.
And our next question, please go ahead.
Hi, this is Dan Goldberg from Politico. In the press release that accompanied Maine's submission plan, you mentioned that there are, or I think Commissioner Lamberg mentioned that there are outstanding questions that need to be answered. Can you address some of what those questions are? What don't you know that you need to know from the federal government? And obviously, I'd like Dr. Dobbs to answer that as well.
Sure. Dan, I'll start. There are two categories of questions. Some of them are unknown policy questions. I'll go back there to the funding piece. What will any potential funding package look like? And then what will the appropriations therein be for? I mentioned to you 4 of the areas that we could certainly use fiscal support on to make sure that all of our architecture is in place. Those are some things that I suspect other states have others. So that's one category of questions. The other category of questions are more on the scientific front. I'll just tee up 1 or 2. The first is, as we are thinking about planning and the order in which vaccines may eventually be approved or authorized, if, for example, hypothetically now, the first vaccine or vaccines that are approved or authorized don't match up with who is indicated in phases 1 or 2, what do we do then? How should we think about that situation? So there's a concordance question. The other is more on the data front. What comes to mind for me is in vulnerable populations, how should we think about vaccine efficacy? Generally speaking, in vulnerable populations, they may not necessarily be included in vaccine trials. For example, pregnant women may not be included in vaccine trials because of the concerns around providing a vaccine, an untested vaccine, to a woman who's pregnant. But then, if they're not included in the trials, how do we generate data in order for us to know which of the vaccines is most appropriate or safe or efficacious? That's a bit of a conundrum that we're just going to need to think through and have, again, it's a question that needs to be discussed and answered.
And the only thing I'll add to that, I agree with everything, is access to National Guard support. We've been the beneficiaries of robust support from National Guard for our testing locations. We offer testing in every county in Mississippi, and we would definitely need their support to run these locations, and I think that's going to be an unknown for us.
Thank you. And certainly to that last point, I think is just a clear example of how this truly is an all-of-government effort, that it's not just the public health sector that has responsibility and capacity to launch such a significant activity. Next question, please.
And our next question, please go ahead.
Hi, it's Maggie Fox with CNN. How much support do you have any idea you've got coming? You've asked for the $8.4 billion plus the $500 million. Federal health officials are a bit vague about what's coming and when. Do you have any picture of what kind of federal support you're going to have? Do you have any kind of picture of how organized your members are? They've got some plans, but how close are they to accomplishing their plans?
Sure. So this is Jim Blumenstock. I'll start. So it's an excellent point, and as it stands now, we do not have any visibility on imminent plans to fund the actual implementation of the plans. As some of you may know, CDC did provide to the states and territories $200 million. That was basically for pre-event preparedness and planning, but that certainly would not be sufficient at all for a campaign of this magnitude and duration that we are thinking of. So the issue of resourcing is a time of the essence matter, because as you all know, even if the money was appropriated today, it will take time for those funds to reach the jurisdictions that in turn would need it to build out the capacity and capabilities that Drs. Shah and Dobbs talked about a few moments ago. So that's a critical point that can't be overlooked in this conversation. And just for context, when we look back at H1N1, the funding for that effort for just the vaccination campaign was over $1 billion. And when you could contrast what now seems to be such a simple process of issuing pandemic influenza vaccine to the population compared to the magnitude and scope and complexity that we're dealing with COVID-19, you get a sense that those seed dollars for planning and other resources that were provided earlier in the year for case identification and testing and contact tracing will be woefully inadequate to sustain this campaign for the year ahead. Again, Dr. Dobbs or Dr. Shah or Claire, any specific examples you'd like to share?
This is Nirav. I guess I will add only that, again, to underscore the need for additional funding, we have received in-kind support, deployed persons, individuals from CDC who have been deployed in person or remotely to assist with things like informatics and planning, but we certainly need more.
Thank you.
Yeah, nothing really to add. And there'll be unknown expenses, especially even in the IT world. That ends up being a really important component to something of this complexity that's going to require some significant investment.
Thank you. And, if I could just add, a couple of items that go along with the planning and preparedness is obviously training and exercising. As you develop these plans, it will be critically important to ensure that all sectors and all components that are responsible for successful plan execution are fully aware of the plans, their roles, responsibilities, obligations, and also, if possible, to put them to some type of through a rigorous examination through exercising before you really need to use them in a real-world environment. So you're not quite sure how much time will be afforded for that type of process, but all that to say is that's just one of probably dozens, if not hundreds of examples that will suggest additional resources are needed for the various components to this overall campaign. Next question, please.
And our next question, please go ahead.
Hi, this is Donald McNeil from the New York Times. In the past, anti-vaccine groups and Russian trolls have been very effective at sending messages that vaccines are dangerous or bad or ineffective. And they've been particularly good at targeting, small groups of people like Somalis in Minneapolis or Hasidic Jews in Brooklyn or something like that. Are you anticipating that something like that is going to happen? And are you doing anything specific to head it off, for individual groups in your states? And if so, what are you doing?
Don, I'll start. This is Nirav, Shah in Maine. We can't speculate as to whether such inroads may be made, but we are aware of, for example, the experience that you noted in the Minneapolis-St. Paul area. In recognition of that, as well as just what is good public health practice, my team and I have, throughout the pandemic, maintained standing meetings and phone calls with leaders of the Somali community as well as other migrant and refugee community groups here in Maine. Cambodian community is one that's near and dear to me, but sizable populations of Congolese and Angolan members, to say nothing of the Somalis that you mentioned. We've maintained standing calls with them throughout the pandemic. About a week ago, in the run-up to our submission of our vaccine plan, convened a special group there to start discussing those issues. My approach, Don, is to ask them what information they need and how we can provide them truthful, factual information that helps them empower members of their community to vaccinate with confidence. So it's not about me dictating what I think the truth is. I want to know what the concerns and questions are that they're hearing so we can provide culturally appropriate information back that allows them to empower their communities as the leaders.
Yeah, and this is Thomas in Mississippi. Certainly, the anti-vaxxer community is a noisy group of folks, but really represent a small number of people. One of our biggest challenges, and we've encountered, is a lot of natural distrust in certain populations, whether it's going to be African American population or Hispanic folks who are in our state. But the same thing is doing some sort of early conversations with leaders in these different areas and with different community members to understand, what's the foundational science of vaccines? Why are they important? How do they work? What is herd immunity? And our early efforts in this sort of approach have been pretty successful as far as getting early buy-in, and it's just going to be a steady, sustained approach, and that's why unified communications are going to be so important. We've seen on so many levels that we have any fracture in that, it does undermine our public health efforts.
Thank you. And Claire, anything more to add?
Yeah, I just wanted to comment. It's definitely an uphill battle to try to stay ahead of the misinformation that's out there. And I think that's why community engagement is so critical. And we're seeing a lot more of that going on with the flu season. Definitely more outreach and communication, establishing these relationships with communities, like Dr. Shah and Dr. Dobbs mentioned, to have these relationships of trust built. And we hope that will have an impact. But certainly a challenge, staying on top of the misinformation and the anti-vax. Yeah.
Great. Thank you. Excellent answers. Next question.
And our next question, please go ahead.
Hi, this is Emily Kopp with CQ Roll Call. I'm curious, given the conflicting statements from the White House and from Dr. Redfield and Dr. Fauci about when a vaccine is going to be available, do your plans prepare for a November 1st distribution date? Are you paying attention to what the president is saying on that? Or are you listening to, the head of Operation Warp Speed and Dr. Redfield, who say it could be a little bit longer? And then I'm also hoping you can address which of the funding challenges that you've listed is the most urgent. Thank you.
Great, thank you. So I'll turn to our two state health officials to give a sense of the timeline for your first phase plan, part of your plan.
Dr. Dobbs, you want to go first? You want me?
Yeah, you go ahead.
Okay, so on our end, our plan is less predicated on a date and more based on the data that would be driving that date. So we're not so much focused on whether it's November 1, December 1, January 1. Our approach is let's be ready, irrespective of when the first vaccines receive approval or authorization. Certainly the more lead time that we have, the better we will be able to be prepared on day one. But for us, it's less about a date that we've circled on our calendar and more about knowing that we have a certain discrete checklist that we need to have in place whenever a vaccine is approved or authorized. And that, whether that's November 1 for phase 1A or whether it's June 1, our goal is to be ready to go. And in respect to that, we listen to all of the various the federal officials with whom we interact with, both Operation Warp Speed and the CDC, as well as briefings from the FDA and others. We know that there are a lot of moving pieces. Our goal is to take that information, filter it through, and make sure we're ready on the state side. With respect to the challenges, I hear where you're coming from, but the candid answer, at least as to Maine, is that they are all equally pressing. I don't know that I could rank order them in sufficient fashion. They are all pressing in their various and distinct ways. For me, it's really right now 4 legs of the table. I don't know which of those legs is more important because without having all 4, our infrastructure won't be where it needs to be.
Yeah, and this is Thomas. I'll agree with Dr. Shah on that last point. And then also, as far as anticipating a date, realistically, we don't anticipate that vaccine will be available for...
Mrs. Claire, totally agree as well.
Yeah, we don't think we'll have anything available real soon, but we're operating with the understanding that if it is available sooner than we think it is, we'll be ready to go, at least with phase 1.
Okay, thank you. And I'm sorry, Claire, say again, please. Great. All right. Let's go to the next question, Katrina.
Thank you. Next question, please go ahead.
Hello, this is Angelica Levito from Bloomberg News. I'm just wondering, how soon after a vaccine is authorized or approved will states be ready to start actually administering those vaccines?
This is Thomas. As soon as we get it.
Yeah, go ahead, Dr. Dobbs.
I think as soon as we get it, we're ready to give it.
Great.
Yep, that's the case on our end as well, at least as to phase 1A. And, as soon as we get word, we've been working very closely with hospital systems as to phase 1A to set up those closed points of distribution pods. So we're standing by.
Excellent. Thank you. Next question.
The next question, please go ahead.
Hi, this is Candace again from the AP. Regarding funding, Dr. Dobbs or Dr. Shah, do you have an estimate on how much funding you'll need to carry out the vaccination campaign in your state and what your current shortfall is? Like, have you worked out a budget, understanding that there are many unknowns?
You know, on our end, we've been, this is Nirav, Shah in Maine, we've been putting pen to paper to really kind of plan out down to the person, you know, looking at how many miles public health nurses may have to drive, things of that nature. We're starting to build a model to be more specific as we are discussing, for example, with our own state legislature, what our needs are. I don't have a number today because a big piece of it comes down to handling of the vaccine, things like cold storage. So it's one thing for us to buy a bunch of -80 freezers for our warehouse here in Augusta, but am I going to also need cold storage to get from Augusta all the way down to southern Maine? Until I know what the stability data around the vaccines are, it's difficult to build out exactly what our budget looks like. So we've got some of those. To the earlier question from Dan from Politico, we've still got questions like that make our granular planning more difficult. Directionally, we know that it's going to be a significant expenditure, but we're still working to put, you know, really concrete numbers on
it. And this is Thomas. I would say the same. We don't know for sure, but sort of by analogy, we got $90 million for the response effort as far as like contact tracing and some other lab support, and I can't imagine that the complexity of this, it would be less than is expected from those efforts.
It's a good benchmark or reference point. Thank you. Next question.
Next question.
Hi, this is Nate Wexel with The Hill. I had a question about the cold storage, which was sort of just a touchdown, but just how much of a challenge is that going to be? I mean, whether it's getting the necessary freezers, whether it's transporting, I mean, how much information are you getting and how much infrastructure are you going to need to build up to be able to get to the point where it's feasible?
Claire, maybe if we could ask you from the national snapshot perspective, what your immunization manager membership was thinking about on that?
Sure. I mean, I think ideally what we'd like to see happen is for the vaccine to get shipped directly to the provider site and to be able to be used without complicating storage and handling on site. But the complex issues with the cold chain with some of the vaccines is also the number of doses being shipped. So a minimum of 975 doses in what looks, to be probably the early vaccine candidate. And that's just a real challenge because, that needs to be spread across perhaps multiple sites. So it's definitely the challenge. We have our members looking at contingency plans as far as assessing cold storage capacity across the state with their providers, with their institutions, with their hospitals, and then assessing their ability to transport. But ideally, looking to set up clinics at sites where they can use the vaccine before they would have to store it. In other words, thaw it and use it while it's still viable.
Thank you. And Dr. Shah, Dr. Dobbs, anything more to add?
Nothing too concrete. You sort of teed up a lot of the key issues. Much of it will depend on the data that we ultimately receive from stability studies. We're also concerned on the supply chain front about what the availability of such cold chains will be, both from an immediate perspective for manufacturers, but then also what we will need once those freezers arrive. Again, it's all well and good to have them in our warehouse, but if we can't utilize that and maintain that cold chain all the way to the point of administration, that undermines our efforts. So I think there's more to come on this. I think it's an example of the reason why state health departments are being flexible. This is what we do. It's what we've done since day one in the pandemic. As we learn more, we adjust.
Excellent. Thank you. Next question.
Please go ahead.
Hi, this is Dan Goldberg from Politico again. Do you have any concerns about data privacy? I know the CDC has been asking for some identifiable data that they would then de-identify. Do you have any concerns on that regard? And if so, can you help us understand what they are?
So, Thomas and Claire, I'll start us off. Dan, I've got a general concern and then a particular concern. On the general concern, we always want to maintain privacy and data confidentiality. So, we kind of go into efforts of this nature with the idea that the more we can keep identities discreet and not share them, the better off it is. In this situation, things are a little different, though, because of the need to send out reminder recalls on day for 21 or 28 day. The situation is a little bit different. Having that personal information might be useful. The other specific concern that this raises is that against the backdrop of what is already a generalized concern around vaccine hesitancy and a trend that seems to be going in the wrong direction, concerns around individuals' identity being known beyond the state raise questions about whether that will hinder our efforts to generate vaccine confidence. The more people know or think that their private health information, their names, are being shared widely, that could be seeds to sow mistrust.
Yeah, and this is Thomas. We do, in our current situation, we do have a centralized registry and would certainly maintain the same privacy protections that we would do under normal circumstances with all vaccines. But I do share Dr. Shah's concern if there are moves to release information that, from a federal perspective, that could potentially be identifiable, that needs to be thought through very clearly and make sure that anything that's released are under the clearly defined standards of the identified information, such that individuals could not be particularly picked out.
Thank you. Next question.
Our next question, please go ahead.
Hey, this is Emily with CQ Roll Call again. I'm wondering if you can expect guidance from CDC on these cold chain concerns soon. And I'm also wondering if you're hearing concerns about a shortage of dry ice.
Claire, you may be a little bit closer to that with the CDC communication than I am.
I think we are expecting a lot more detail from CDC on the cold chain. I know for AIM, we just had a 2-hour session with Pfizer just reviewing the packaging that their vaccine will contain, and there were still a lot of questions. Pfizer's still studying the stability of the vaccine as well. So I think there will be a lot more guidance coming out. There will be an addendum to the vaccine storage and handling toolkit that will specifically address the COVID-19 vaccine. So there's going to be a lot of detail coming out, and we'll have to translate that detail to training the providers and those receiving the vaccines. I missed the second part of your question. I'm not sure if you said there was a shortage. Was that dry ice? Was that? I'm sorry, I didn't hear that.
Yes, that was the question, Claire. Can you confirm if you've heard about a dry ice shortage regionally, locally, or nationally?
Yeah, so our members have been talking about that. They've been looking into getting dry ice, and they have been hearing that it's difficult to find. It may not be available in some states. We have reached out to Pfizer about that, and they have told us that they are working to identify more dry ice providers. So I think it's just we're not used to working with dry ice, so we're not really sure exactly where it's available, just really trying to identify all those places right now and working with those who do work with dry ice to find out.
Thank you. And Dr. Dobbs, anything more to add?
Well, we've thought about it, although we haven't heard any direct communications, but kind of like anything that has increased demand, obviously it's a concern.
Agreed. And, in the discussion of ultra cold chain, cold storage, and dry ice, that's just one good example of sort of, the new planning challenges associated with COVID-19 that didn't exist with other types of traditional vaccines that the public health and the commercial sectors need to adjust and address accordingly. But that takes additional time and effort to get it squared away, which is clearly a work in progress at this point in time. Next question.
Next question, please go ahead.
Hey, it's Maggie Fox at CNN again. Can you kind of summarize what you've been hearing from your members about the various challenges that they're seeing in planning for the vaccination distribution? And Dr. Dobbs, you said one thing that struck me. You all have received almost no federal support, but you say you're ready to start giving vaccines on day one. How do you reconcile that if you've got absolutely no support yet?
So this is Jim. So let me take the first question first, then I'll yield to Dr. Shah. So I think one of the many reasons why we asked the state health officials from Maine and Mississippi to speak with you this afternoon is because they really are, while they have unique features of their own geography and demographics and cultures, they also are a great representative of all the other jurisdictions. Really addressing this issue head on to have the tightest, most effective plans possible. So where they've sort of talked about their progress, the obstacles, some of the challenges, the length of the to-do list, I think that would be clearly representative if we had any other state or territorial health official on the line with you today. Those issues are not unique to the two states with us this afternoon. So with that, could I turn back to Dr. Shah to talk about sort of, in the context of resources, how does that impact your immediate versus longer term state of readiness to respond?
Sure. I'll touch briefly on the note that you kind of the more general holistic view from other 50 states. And while I certainly can't speak for anyone other than myself and my agency, in conversations that I've had with my counterparts several times per week, almost every night with different groups, I think the concerns that Dr. Dobbs and I and Claire have shared are representative along the lines of what Jim noted. Funding coupled with the need to ensure that the most vulnerable within our states are the first ones in line. The way that we are balancing, and I'll turn it to Dr. Dobbs, the way that we're balancing this is the recognition that Phase 1A in particular is quite discreet. It's healthcare workers on the front line, and it's a vaccination that occurs at a site that is already set up, that is to say the hospitals themselves. When we start getting into 1B, and then into Phase 2, that's where, for us, the human resources needs to have a large team of vaccinators. That's where that concern really kicks in.
Yeah. This is Thomas, and I agree that the first phases are laid out a little bit easier and easier to execute. And maybe my faith is misplaced, but I do have faith that funding will be made available in time for vaccine distribution, especially as we get into the more complicated general public open points of distribution sort of scenarios, which would be very, very costly.
Thank you. So again, the resourcing is driven in large part by the magnitude and duration of the campaign, and that is a sort of the significant difference between the initial phases and startup versus a more intense, longer term campaign, recognizing that we're targeting upwards of hundreds of millions of individuals, many of whom will require a second dose. So that's a times two as far as the number of vaccination encounters the public health and healthcare sector has to plan for. Next question.
Next question, please go ahead.
Hi, this is Donald McNeil from the Times again. Sometimes when you do a big vaccine rollout of millions of doses, you get rare side effects, Guillain-Barré syndrome or other things like that. And I know that one of the concerns with coronaviruses is the possibility of immune enhancement from vaccination. What are your plans for long-term follow-up in these cases, for long-term surveillance? I mean, if you hand out 1.3 million doses in Maine, people standing in long lines, how are they going to be able to report, or their doctors going to be able to report if they have any problems that you might want to collate in some way, rather than just waiting for newspapers to pick it up?
Yep, Don, I'll start and then ask Dr. Dobbs to weigh in. But part of our deliberate IT planning process right now is not just sort of who got vaccinated on day 1 and then on day 21 and 28, but making sure we've got a system to follow up with people either directly or via their healthcare provider. We're still waiting guidance as to which route will be better, but that we can participate in the requisite phase 4 monitoring and evaluation processes that we anticipate will occur with these vaccines. And we're planning around that so that our IT system can handle that, not just from a data logging perspective, but also from a sort of a hypothesis generating perspective. So if we start seeing reports of individuals experiencing weakness in their legs that could be consistent with Guillain-Barré, one, are we going to be able to see those flags? And then two, are we going to be able to work with the patients to make sure they're getting evaluated properly? And then those data can then be sent up to the CDC. What that will eventually look like, I think, is still TBD, but it's certainly a consideration. It's part of our planning right now. To go back to something I said earlier, the vaccine is just one part of the story here. It's all of these other semi-visible or invisible pieces that are just as critical, like you say, with the vaccine follow-up and monitoring.
Yeah, I agree. We'll certainly have accessory mechanisms for ensuring that any sort of rare events are duly noted, but there are pre-existing mechanisms for doing this that we do every day anyway, through like the VAERS, the Vaccine Adverse Events Reporting System, and there'll be just a mountain of data being generated through this whole endeavor.
Yeah. And the key point to remember is that it's quite possible that we will be tracking multiple vaccines that have been applied to the population over time. Next question.
Don, could I just make one really quick mention, though, Jim? This is why I think state health officials are so critical for this process, because we are, for many people in our states, the face of COVID-19, and I think we have an obligation to be straight with people about what we know, what the risks are, what the potential, albeit rare, adverse events that might occur are. This is why state health and state public health is so important right now, because we're able to take this abstract or clinical data that's generated and viewed by FDA and ACIP and then translate it for our communities and be the face of that trusted information. This is what state public health does, and it's why it's so critical right now.
Thank you. Excellent point. Next question, and I believe we have probably time for 2 or 3 more.
Okay. Your line is open. Caller, if you depress your mute function.
Hi, this is Ping from National Public Radio. I wanted to ask you about the ASTHO recommendations. So the CDC Federal Advisory Group says they're not going to make recommendations on priority groups until a vaccine has been authorized, but it sounds like your states are pretty clear about what your priority groups are anyway. So I wanted to ask, what are you looking to ACIP for in terms of recommendations, and how do you imagine that might impact your preparedness?
This is Claire. I can start with that one. There are assumptions included in the playbook, and there's also some guidance put out by the National Academy of Medicine around who would be likely to get the vaccine first. And so we are working with that. The phase 1A, healthcare workers and essential workers, and the phase 1B, adults with comorbidities. So we do have those assumptions to plan on. But yes, really looking to ACIP to evaluate the data and to make recommendations around where the vaccine should be used and who should be prioritized. So it's important to plan, but it's also important to have that flexibility and to look to the expertise of ACIP.
I'll chime in on that as well. This is Nirav from Maine. I happen to have the honor of serving as ASTHO's representative as an affiliate member on ACIP, and it also happens that our counterpart in the state of Arkansas, Dr. Jose Romero, is the chair of ACIP. And so state health officials have been deeply involved in this process. The way we are looking at it is that we're looking at the national academies to give us a compass view of who should be vaccinated and the ordering, we're looking to ACIP for which vaccines. Dr. Romero, the chair, has noted to us that as soon as the data are ready for review by ACIP, perhaps the day or the day after the vaccine receives approval or authorization, ACIP is standing ready to meet and convene and start issuing recommendations. So that's the speed with which Dr. Romero is conceiving of ACIP acting. In my own capacity as an affiliate member for ASTHO, I've noticed that's been the tenor of discussions on ACIP, which is to say as soon as the data are available for review, the members of ACIP can start meeting to talk about which vaccines should be appropriately used for the populations that the National Academy has organized.
Thank you. Next question.
Next question, please go ahead.
Hello, this is Angelica from Bloomberg again. I wanted to follow up in terms of vaccine administration readiness. So when you look at the plans, some of these phases include pretty broad groups, so people with comorbidities. I mean, how will the states manage actually finding out who these people are, making sure they actually have those comorbidities, and making sure there's enough vaccine available to vaccinate them all?
I'll start real quick because that's been top of mind for us in Maine. It was not lost upon us that in Maine, at least, once you get through Phase 1B and maybe the early stages of Phase 2, given our older than average population and the high number of chronic diseases in Maine, that's a large swath of the Maine population, and you're not even partway through Phase 2. So we've talked about two things. The first is using what the National Academy recommended, which is that within each of those priority groups, we are doing micro-planning. So within 1B, we are looking at not just the individuals with significant comorbidities, but then looking at ordering by exposure risk as well, per the National Academy recommendation. And that's one of the planning questions we're working on right now. Separately, to your latter point about even understanding who has comorbidities. On a call that I convened last week, on a call that Governor Mills convened last week with leaders of the health systems in Maine, we asked for their assistance in helping us get a better sense of who within their patient populations that they serve would fit into Category 1B, which is to say folks with chronic medical conditions. So it's going to be a partnership with health system leaders to make sure we're addressing those populations in the right order.
This is Claire. I just wanted to add, as part of the readiness piece, this fact of enrolling providers and casting a wide net across the state to gather private providers, local health departments, hospital systems, pharmacies, and get them to enroll. And as they complete the enrollment process, they do complete a provider profile information form. So, they know what kind of patients they serve, and they know those patients better than anyone else. So getting those providers enrolled and getting their profiles completed will give a better sense of how many and who they are and where to reach them, and also improve the readiness in having providers spread out across the state. So as vaccine becomes more available, utilizing different accessible points for people with comorbidities.
Thank you. I believe we have time for one more question.
Okay, and our last question, please go ahead.
Hi, this is Elizabeth Weiss with USA Today. So a question I had is, we know that there's going to be tremendous interest on the part of CDC, and I'm presuming Congress as well, to get information back as absolutely quickly as possible on how many vaccinations have been administered in each state. Is the IT system going to be able to provide information at that level of speed, do you think?
This is Thomas. The human factor is going to be huge in this. As far as once it gets in the system, assuming that the appropriate data linkages are able to be put together. On our end, we feel pretty confident we'll have it. That's going to be one of these huge logistical challenges, is making sure you have the systems and the personnel in place to really do it, because this is going to be a Herculean effort.
I'll add one thing that we have started working on. In Maine, providers are required to submit for all vaccinations. They're required to report those, most providers, not all providers, are required to report those to our registry within 5 days of administering the vaccine. But for COVID, given the need that you noted for data to be updated and refreshed every 24 hours, we have started alerting providers in Maine that when it comes to COVID vaccine, they're going to be having to report into our IT system every night rather than every couple of days about the number of vaccines they've administered. We're simultaneously pressure testing our IT system to make sure it can withstand that influx of reports that we anticipate receiving. So it'll be, as Dr. Dobbs noted, a bit on the human element. Providers will have to make sure they are reporting in every 24 hours, and then we're going to have to make sure our system can accommodate that.
Excellent. Well, folks, unfortunately, our time together this afternoon is coming to an end. So first, let me certainly thank members of the media for your hours spent with us and for the level of questioning and really, driving home many of the questions or points that are important to us and really go to illustrate the level of complexity and criticality of state planning efforts. My takeaway here in listening to the conversation, I hopefully you will all agree that, number one, our panelists have clearly, documented or shared with you that much progress has been made in planning, but much more remains, and planning will continue in a very aggressive fashion, in the days and weeks ahead. I think we sort of talked about, what really goes into a successful planning effort. An articulation of those pillars or those components of human resources, information technology, logistics, including transportation and operations, and obviously health and risk communications, all of which need to be properly resourced for the long-haul effort around this campaign. And the last thought I want to share with you, while we really didn't touch upon it, but I think it really is worth mentioning it, that while we will work so hard to ensure that a safe, efficient, and equitable national vaccination campaign is launched and continued through a successful completion, that doesn't negate any efforts associated with prevention. It is still critically important in order to properly protect the health of everyone in this country and in our global community as well, that vaccination has to go hand in hand with the preventative measures of face masking, social distancing, and personal and facility hygiene. So please, if we were to ask any sort of parallel message to be conveyed in today's hour conversation, that key feature not be lost in our discussions and reflection of today. So with that, Dr. Shah, Dr. Dobbs, and Ms. Hannan, I want to thank you on behalf of ASTHO and all the people you serve for your leadership, your contribution, and obviously representing our membership today during this media availability. Anyone who has a follow-up question for ASTHO, please feel free to reach out to Jane, and I believe you have her contact information, and ASTHO will continue not only to stand ready to support our members and our federal partners through this, but also to be a voice and a pathway for information to share with you so that you could objectively report on the progress being made in this particular public health issue. So with that, I want to thank you all very much. This concludes our call for the day, and you